I'm Dr. George Vetrovec, Emeritus Professor of Medicine, VCU Pauley Heart Center at Virginia Commonwealth University in Richmond, Virginia. I'm here today at the World Congress of Cardiology in Boston, and I made a presentation earlier today on the role of hemodynamic support in the management of patients with acute myocardial infarction and shock. Several points that I made are worth reviewing. First, surprisingly, despite the fact we're doing so much better in managing acute myocardial infarction, we are seeing a higher percentage of patients with cardiogenic shock. And I think this is really a product of the fact that we've gotten people through what used to be fatal initial events by reperfusing earlier and all the management strategies we use for patients with heart disease. Now when they present with a heart attack, many of them, particularly elderly, are at the further stage of heart disease, and so they have less margin. And so cardiogenic shock then is a greater component of this. So in trying to improve outcome with cardiogenic shock, we know several things. We know that patients with shock are sort of in an adverse positive feedback mechanism where they get increasing catecholamines, they get increasing lactate levels. Everything that they do that's compensatory to try to maintain blood pressure are really negative to the heart performing well. Now, we've done well with door-to-balloon time in terms of salvaging myocardium, but we've sort of maxed out that. So we can't get improvement. It's been demonstrated by getting that time any shorter, for instance. So we have to look for other strategies. So all of the things that we've been doing along the way to manage shock, such as adding inotropes, don't really help the failing heart. They work against it. So the thought is that if we can do something with hemodynamic support, we may be able to interrupt this adverse cycle that's going on and improve outcome. And so the possibility is to consider earlier and more effective use of hemodynamic support devices. What do we have available? The intra-aortic balloon pump is actually a misnomer. It's not a pump. It does increase blood pressure. It does increase coronary flow to some degree, but it really doesn't significantly change cardiac output. And when you look at the risk of patients with cardiogenic shock, particular finding is that cardiac power output is the single best predictor. And to improve cardiac power output, you have to increase not only blood pressure, but you have to increase cardiac output or forward flow. So the intra-aortic balloon pump is really not an ideal tool. And that's been supported by multiple studies showing that its effect in shock and heart attack does not really change outcome. So we're left with then what are other devices? ECMO, which is very popular with surgeons, is not particularly ideal with acute MI in many circumstances. It can take longer to put in. The other thing about it is that it doesn't unload the ventricle. It provides excellent cardiac output and it provides excellent oxygenation. But the filling pressures in the heart either don't come down or increase, which is expensive to the myocardium. Now, the most ideal device that's available now is the Impella, and it's just recently received FDA approval as a device for management of AMI cardiogenic shock. This device improves cardiac output, improves blood pressure, improves coronary flow, and it reduces filling pressure of the left ventricle. So the combination of better coronary perfusion, better cardiac output, and reducing filling pressure has the greatest opportunity to salvage myocardium by optimizing coronary blood flow and myocardial perfusion. So this is an ideal device. Now, in the one really important study that was done from a registry that showed that patients who got the device put in before they got coronary intervention in AMI shock, they actually had the best overall in-hospital and 30-day outcome. So not only is it an ideal device, I think the data suggests that in this syndrome, we really need to be quicker at using these devices to improve cardiac function, improve perfusion, and hopefully we can make a bigger difference in cardiogenic shock.